This is a quick summary on vaccines. Uh, Intradermally, given vaccines are given 15 degrees angle to the skin with the usual dose of 0.05 ml. BCG is a live vaccine given intradermally, and subcutaneously given vaccines are given 45 degrees angle to the skin with the 0.5 ml usual dose using a auto disable syringe. Normally given subcutaneous given vaccines are uh, Japanese encephalitis vaccine, MMR, rubella, measles, and chickenpox. And there are intramuscular vaccines. Usual dose is also zero point 0.5 ml. It is given 90 degrees angle to the skin using auto disable syringe. Uh, so pertussis vaccine and the tetanus and diphtheria vaccines. Tetanus and diphtheria vaccines, these three are given IM route, and tetanus and diphtheria are toxoid vaccines, while the pertussis is a killed vaccine, uh, and the oral vaccines are given for polio, polio actually type 1 and 3, and also for rotavirus and typhoid, they are given orally. So next, the monovalent vaccines are the vaccines that are against a single strain of an organism. Polyvalent vaccines are multiple strains can given to the multiple strains of the same organism or against several organisms also. So there are vaccines called conjugated vaccines. Actually, when children are less than 2 years, they can't produce antibodies against the polysaccharides. So these polysaccharide vaccines are combined with the protein in order to boost to make the immunity in especially children less than 2 years of age. So usually vaccine given areas are this deltoid and lateral thigh area. The deltoid area, in order to give the vaccine, we have to locate the chromium process and measure 3 finger breadths below it and inject at the midline above the point. And the lateral thigh, uh, we have to give to, to the medial one third of the thigh lateral to the midline, this area. So this is the EPI schedule of Sri Lanka. So BCG vaccine is given at birth and at 2 4 6 months, the pentavalent vaccine is given, which is IM vaccine. Pentavalent vaccine contains diphtheria, pertussis, tetanus, Haemophilus B, and hepatitis B. 2 4 6 months. Also, the oral polio vaccine given, which has the vaccine against type 1 and type 3 of the polio strains, and it is a oral vaccine. So at the 2 months and 4 months, we give FIPV, that is the fractionated intradermal polio vaccine. It's a type 2 vaccine. It is given intradermally. So this because previously oral polio vaccine was given with all three for all three strains, but later it is found that type 2 can cause since it's alive, type 2 can cause the disease also. Therefore, uh, they change it to the fractionated intradermal uh, vaccine, which can contain type 2 and given at 2 and 4 months after the birth. At the age of 9 months, MMR first dose is given, which is a subcutaneous vaccine. At the age of 12 months, live JE, live Japanese encephalitis virus vaccine is given, which is also a subcutaneous vaccine. At the age of 18 months, the fourth dose of this DTP and oral polio. DTP is diphtheria, tetanus, and pertussis. Four doses given, and It is a IEM vaccine, the DTP vaccine, and the polio is given orally. At the age of 3 years, MMR second dose is given, which is a subcutaneous vaccine. And at the age of 5 years, at the school entry, DT and oral polio is given at the fifth dose, and after that, there's no oral polio. So, oral polio is given at 246, and the FIP given 24, and then at the 18 months, and then at the age of 5. At the age of 10, human papillomavirus 1 and 2 vaccine are given to girls at the 6 months at 6 months apart interval, and at the age of 11 years, adult tetanus uh, toxoid vaccine is given. It can be given to 11 to 15 years also. So usually given at 11 years. So now let's talk about precautions and important things about vaccines, about machine vaccines, delays, and everything. So precautions. Uh, Vaccines should not be given if an anaphylactic reaction has occurred to the same vaccine with the previous dose. But if a mild allergic reaction has occurred, it can be given under close observation, especially at the ICU or a HDU-like setting. We can give. So, when should we postpone the vaccines? If a child is having an acute febrile illness more than 100 degrees Fahrenheit, we can postpone the vaccine. If live vaccine is given less than month ago, we have to postpone the vaccine. If blood or blood products, immunoglobulins are given within 3 months, we have to postpone live vaccines, not the other vaccines, live vaccines. If chemotherapy is given within 3 months, we have to postpone the 3 months. This is also for live vaccines. And major cardiac surgeries is also for live vaccines. Uh, so usually this is because these live vaccines contain the virus or the toxoid. Therefore, in these immunocompromised states that can cause the disease, which is but it is very rare. But there's a tendency to cause that. So, live vaccines are best avoided in these situations. Avoided in reticular endothelial system malignancies during the first 3 months of pregnancy, and in immunocompromised people. In live vaccines and steroids, like in nephrotic syndrome, in child we give steroids. So we have to postpone or delay vaccine sometimes when the child is on a high dose steroids, and that is high dose means more than 2 milligram per kilogram per day for 2 weeks or more. So we have to give vaccine 1 month after the stopping the drug. Uh, so that means if the we have to if the child has nephrotic syndrome, we have to give the drug in the remission period after 14 days of after 1 month stopping the drug. So if the child is on low dose steroids, that is point point 0.5 mg per kg per dose, we can give steroids immediately after stopping the drug. Steroid replacement therapy, uh, or in topical steroids, we can give the vaccine while on the drug. No need to delay the vaccine. In premature low birth weight children, there are no exceptions. Can proceed the same EPI schedule. If the child has a seizure, live vaccines, especially live Japanese encephalitis, not given if a progressive neurological disease is there. But if there is no progressive neurological disease, we can give live JE delaying only 1 year. So having a family history of epilepsy or seizures is not a contraindication to give give live vaccines. But if there's a progressive neurological disease, we do not give live vaccines. But for non-progressive, we uh, take an interval of 1 year and give the vaccine. So multiple vaccines. So multiple vaccines can be given on the same day, but at different body site, not to the same body site, but for the different body sites, we can give multiple vaccines. So it is important in when we give missing vaccine doses, this multiple vaccine policy. So for missing vaccines, we don't do no need to restart the vaccination and can use the multi-dose method at different sites, but not the same vaccine. These multiple doses can be given from different vaccines, but not the same vaccine. If the same vaccine is missed, we have to uh, have a 4 to 6 weeks apart between the same vaccines usually. So minimum gap between two live injectable vaccines. That means two live vaccines. That should be 4 weeks minimum. So usually 4 to 6. So no specific gap between oral and live vaccines. If we want to give oral vaccine and a live vaccine, then we can. There is no specific gap. Can give and inactivated vaccines also there are no gaps. Then if in live and inactivated vaccines also no gap. So as you know, there are adverse effects following immunization in Sri Lanka. So this is the usual way of notifying the adverse effects following immunization. So adverse effects following immunization, there's a form, you have to fill it, you have to give it to the MOH of the patient's residing area. Then MOH prepares the monthly adverse effect following immunization return and send it to the epidemiology unit and they investigate. So if there's a very specific allergic reaction like anaphylaxis, which is a very specific and reaction, we can directly inform the epidemiology unit and ask them to investigate. So it's a quick summary. Thank you.